Tobias and Emily, please feel free to take it from here.
Sounds good. Thank you for having us today. I'm excited to host a webinar together with Emily, our client from UTMB. Just to give you a little bit of an overview, what we'll cover. We'll give you the state of the market, or at least the way we see it on the patient revenue cycle. We'll talk about opportunities to optimize pre-service and post-service, and then we'll talk about considerations of choosing an external partner for affordability, and then we'll have some time for the Q&A in the end, as indicated in the intro. Obviously you already got a bit of an introduction on PayZen, so I'll just add a little bit of context to it. So when we started PayZen, we saw an opportunity to really improve things for both patients and providers in the context of increasing patient responsibility. We saw an opportunity to apply kind of the latest state of the art of fintech to this problem. When we looked at existing solutions in the market, we saw a lot of legacy patient finance players and a lot of financial engineering, but not a lot of real engineering and technology. And we think by bringing real technology and data science to patient affordability, we can have better financial results for the hospitals and a better experience, better access for the patients. Maybe Emily, give a little bit of background on UTMB as well.
Sure, thanks, Tobias. So I'm from University of Texas Medical Branch, and we are part of the UT system. We're a about 130-year-old academic medical center, and actually our main campus sits down here on the island. We have over 53,000 residents on Galveston Island, but we have grown quite significantly. We actually now have 4 campuses. We have 3 campuses on the mainland, in addition to, like I said, our main campus on Galveston Island. And we also have about 100 clinics across the region that offers both primary care as well as specialty care. And I would say, in addition to our focus on the patient's clinical experience, certainly it's very important to us that the patient also has a positive financial experience. And this has really been our focus over the last few years. And certainly, post-COVID or post-epidemic, when the economy really went belly up, we certainly started to see our bad debt numbers rising pretty significantly. And so we really are, I would say a year post-COVID, really putting a lot of effort into recovering from that. And, the estimates, point of service collections, and PayZen has really been part of this journey with us to help us provide that positive financial experience for our patients.
Thank you. Excellent. So, just to set the stage a bit, like the major trends in the market really haven't changed over the past few years. Patient responsibility continues to increase. I think hospitals continue to have low payment or low collection rates in the 20s to 30s overall. I think the current economic situation with pretty good headline numbers in the economy, but if you kind of look below the surface, certain groups and families are certainly feeling the pinch, especially lower income, kind of lower FICO demographics, and you can see that show up in patient payments overall and in performance or payment adherence on in-house payment plans. You can see it out there in the consumer credit market as well. Despite the good headline economic numbers, groups of people are feeling the pinch. If we talk about price transparency a bit, and then kind of increasing out of pocket. I think what goes along with that is, a continued big part of the population that says that they're deferring necessary medical care because they're worried about the out-of-pocket expense. And really, I think that's another area of opportunity that we'll cover here. Overall, we see in the patient revenue cycle, many processes are still manual. Educating a patient about the options that are available to them, getting a patient on an in-house plan, or dealing with things like adjusting a balance, canceling a plan, processing someone who's already paid for financial assistance because after the fact they turned out to be eligible. These are all kind of in most cases manual processes that are either on the rev cycle stuff or on vendor stuff, early out stuff, and that's happening against the backdrop of continued staffing shortages and staffing challenges. What's been added to this mix is more attention from the regulators, both at the federal and the state level. Clearly at the federal level, a big headline pieces of legislation is no surprise, Bills Act, but then also at the federal level, regulators like the CFPB are increasingly looking at the patient revenue cycle and at collection and servicing practices. Like they had a particular focus around things like interest, retroactive interest that patients can get into, or taking a balance that is a medical balance and is protected as a medical balance, and converting it to a financial balance where you can have different credit reporting, where you can do different things on the recovery side, and then finally also getting people in financial products that should be eligible for financial assistance. So those are all kind of focus areas that CFPB looked at a federal level, and then various state regulators kind of have started looking at the patient revenue cycle as well, with those same kind of general direction, making sure that a medical balance is kind of treated as such and has some protections on the collection side, and then looking at kind of debt sales, financial products, making sure the patient retains those protections and remains eligible for financial assistance if their financial situation warrants it. What kind of all these factors have in common from our perspective is that they can be solved through data, automation, kind of a tight integration back into the host system. The EMR can really improve both the experience for the staff and for the patients. And then maybe let's get the poll started, and Emily, maybe you can cover the areas that you're most focused on, or kind of where your eyes at in the patient revenue cycle these days.
Sure. So I would just add two things really to what you said. You were talking about, bad debt, self-pay balances rising. And, when we look at our bad debt, we do separate out, our unfunded population versus our balance after insurance. And really, even in the balance after insurance population, we've significantly seen, our bad debt increase. And so, you would almost say that that's low-hanging fruit. But to your point, a lot of these patients, want to pay their medical bills, and just really, need a better option in order to do that. So I think it's important to kind of separate, or at least, from a data perspective, to look at, because you are going to have some unfunded population that's not necessarily going to have the ability to pay, but also a large population like your commercial population. And although those, the patient liabilities have gone up, you still have a higher, I guess, propensity to collect money from that insured patient. So I think that's important. And then on the slide before, we talked a little, or you showed about care avoidance. And I just want to make a a point to where, in our organization, and I'm sure there are other organizations where, if you're not necessarily requiring the full amount up front, or if it's even, something where your physician or your surgeon is saying that it's an urgent type procedure, a lot of times, because we get in that, sort of back and forth there to, trying to financially clear it, patient isn't able to pay their full amount, but yet the surgeon wants to proceed with the procedure. And so it's not really even just care avoidance, but moving on to performing the procedure, providing the service without collecting that patient liability. And then you're on the hook in the back end. And, obviously, and we all know, your ability to collect that amount on the back end is much less than it is if you try and get it on the front end. So I think that's an important piece of the puzzle.
Yeah, no, that's right. And don't know if we have the survey responses back yet. Yeah, here they come up. Pretty common picture, I'd say, when we do these webinars. I think the two top things that come up is the decreasing payment rates on patient balances, and then kind of staffing shortages and manual work. Pretty consistent picture we've kind of seen across these webinars. If you go to the next page, we talked about this perfect storm, if you will, with increasing patient responsibility, decreasing payment rates, care avoidance, or getting that patient scheduled, and the regulatory, and then kind of the fact that much of this is still manual, add to this the general financial pressure that most hospitals and health systems are under. Really, I think now is the right time and a good time to look at the patient revenue cycle and see what could be improved and how to evolve there. And if we go next page, as Emily indicated, really, pre-service is a big opportunity area. I mean, if you take a step back, the traditional ways, okay, here's the call center that's calling somebody, and then here's some bad debt collections. Kind of the traditional ways are becoming less and less effective. Fewer and fewer people are picking up the phone, and obviously, the regulatory action really have reduced kind of the sticks that you have available, I'd say, on the bad debt side. So really being kind of more proactive, more upfront, more collaborative is a way to go to get better results and a better patient experience. So pre-service is one opportunity area. Clearly when you are scheduling someone, when you deliver an estimate, is the perfect point in time to also talk about payment options and payment. And, the people have kind of a strong process there and a tight integration between those two points: delivering the estimate, scheduling somebody, and asking for payment deposit, and making sure the payment options are figured out pre-service. I've seen really good increases in pre-service collections. Maybe we'll stay on that page just for a little bit longer to kind of set the table of the different options. We get later in this presentation, we get into post-service as well. But the opportunity we see on the post-service side really is having a strong digital experience that clearly communicates around what the balance is. It uses multiple channels of communication. Clearly, if you supplement the traditional paper statement with text message and email, you can better reach the population, and then just making it easy for people to pay. There is like a call and a phone transfer and a package back and forth involved. I think that's our patients are going to drop out. I think if it's kind of easy in the way people are used to in an e-commerce setting, you're going to have better success. And that's also where kind of tailored payment options come in. I think if you target the right patient with the right offer and you tailor it to truly what a patient can afford, then you're going to have better success. This is overall a pretty fragmented landscape. Many hospital systems have different processes or systems for HP and PB. There's, various vendors involved early out, bad debt eligibility statement vendors, payment processors, the EHR. So, what we see here is that, the EHR, especially Epic MyChart, it's becoming more and more the hub of the patient experience. And then the different solutions kind of need to plug in and integrate there. And then clearly this transition from kind of an approach that heavily relies on call centers to something that's more automated, more self-serve. And I think that along with that, a consolidation of service providers, right? If one provider can provide a couple of these things in an integrated way, I think that's going to be preferred. Where do you start? I think clearly for all these things, it's important to kind of have a destination in mind, and then, step by step, build there, and, choose the right partners who are also going to evolve with you, who are going to continue to innovate as you're on this journey to improve your patient revenue cycle. And then, yeah, I mean, without further ado now, I think we can dive into a bit more the patient revenue cycle. Clearly, all the health systems that we work with, because of the regulation, introduced to up their game on estimate. I think what we see as kind of the most popular, I'd say the solution that's furthest along of the vendors is kind of the Epic Estimate or Epic Estimates. It benefits from the tight integration into Epic. Coverage is still not perfect, but it's increasing. Most hospitals we work with are, really still heavily relying on an outbound calling effort to deliver these estimates. And as mentioned before, when you deliver an estimate, it's a logical place to discuss payment options. And then, just thinking about digital engagement around estimates. Pre-service, I think, is still in its infancy. There's some experiments out there, but the majority of what we see is still based on kind of outbound calls and the call center. And then I think if we just go into the poll question, what we want to do, pulse the group at, and what is really decision that we have seen different systems take different approaches is, how strongly do you link kind of the estimate and the scheduling to a deposit? What we found is if you are offering a host of options, so you're, asking for a deposit at the point when you deliver the estimate, but you can also offer some options for the patients that are not able to make it. You can set them up on payment arrangement. We'll talk about, Payzen's offering in this space, care card in a bit, but you're not only demanding something of the patient, but you're offering them a solution. I think then you can be firmer in your ask, and that's clearly going to drive better financial outcomes. We've seen hospitals offer kind of in-house plans and payment arrangements at this stage as well, but there is some administrative complexity involved, kind of adjusting it up and down based on what the actual procedure is. So some folks have shied away from it, and I guess you could see this reflected in the results. I think kind of the most common answers here that you are encouraging a deposit or a payment method, but you don't have a hard requirement around it, and then kind of the rest is kind of sprinkled throughout. Maybe we go to the next page, and you can hear kind of from UTMB. I think I'll just say to preface this, among the health systems we work with, I think they've been one of the most successful implementations of kind of a pre-service initiatives and pre-service collections. So yeah, without further ado, maybe Emily, you can kind of cover what you're doing there and how it's performing.
Sure. Thanks, Teresa. So, I did already mention this, but I would say over the last really probably year and a half, 2 years, a really big focus for even really before PASN came into the picture, really big focus on improving our point of service collections. We are an Epic shop, and we do use the Epic estimate templates. There are areas where we automate estimates, others that, we will create and push out to my chart for our patients. But certainly we're still making, outbound calls to our patients in order to collect ahead of time. Just, back to the poll. So we do require definitely a deposit before proceeding with a procedure. And really, this is where we were very focused, and I'll really say more in the outpatient procedural areas, because it's one thing to collect a copay, but really when you're getting into, an elective day surgery, radiology, cath procedure, any of those outpatient procedural areas where the patient's out of pocket is higher. I was very interested in being able to offer our patients a better option in order to pay those balances. And this really went, PASN went very much hand in hand with what we were looking for in order to solve that pre-service option for our patients. And we've actually, been very successful. We have seen our point of service collections go up. We've seen our bad debt is trending downwards. And so this is actually proven to be, and we've actually gotten really positive feedback from our patients when they are able to utilize the PASN option. We do ask for the full amount, up front, and then we go from there. So we work with our patients, but having this as, an option for them is really very beneficial.
Thank you, Emily. It goes without saying, I think the flip side of the coin on transparency, if you're not offering kind of options to the patients, it has an opportunity or has a risk of increasing, care avoidance. And I think this is what we can see at the tail end of this chart, right? When there was a bigger focus on estimates and transparency, there's been also an uptick of people who say in the survey that they've delayed care for fear of out of pocket. If you maybe just on the next page, just talk a little bit about the genesis of the card. And I think it's kind of an important philosophy of ours anyway, that we develop our products and our technology really in kind of close partnership with our hospitals and hospital systems. So, for the card, both UTMB and Geisinger were the development partners, and the kind of the goal or the mission at the onset was to, create an option that gives patients a peace of mind that they can afford their care. So kind of the idea of a payment plan in their pocket. So, this card doesn't work kind of like a traditional credit card where you are like accruing a balance and then just kind of keeping the balance there and paying interest. Well, the idea is that the swipes you make on the card ultimately convert to kind of affordable monthly payments, and a patient is paying down their balance. And the payments really are tailored to what a patient can afford. So, a patient with a more challenging income situation, we pull a lot of data on the background, is going to see a different monthly payment compared to a patient, who is better off financially. And we wanted an instrument that has the flexibility to be used kind of across various payment methods at the health system. So it could be swiped at the point of service. It could be like taken as a payment method in a phone call, or it could be entered kind of in the online checkout experience. In the end, it kind of all comes together in the card and creates that payment plan in the pocket. And then finally, we wanted an instrument that really gives a hospital the opportunity to market this as a benefit to their population. So you could see here on the image, the card is co-branded to the health system. It is kind of locked down to work at the merchant IDs of the health system. So, if UTMB is providing the card, it won't work outside the UTMB network, which, over time, I think the hypothesis it drives kind of repeat use and drives this loyalty to the health system. I think important to say here too is that, especially in the light of the regulatory scrutiny, that this product never charges interest, never fees, and 100% of patients are approved. So really, if someone patient wants to pay for this and is, trying to do the right thing, we should let them, and we should make things easy for them with this product. Maybe just Emily, kind of any other feedback, anything to add here?
No, I'll just, reiterate and actually just based on those poll results, a lot of folks, are asking for a deposit, but not requiring it. And so that leads me to believe, just like we were doing, letting the patient proceed without collecting that full patient liability. And we certainly found that, a lot of times, because I think the theory is that you don't want to give up the insurance payment and lose volume, for a $1,000 patient balance or $500 patient balance. But we did a study here at UTMB, and more times than not, it showed that if we didn't collect the patient liability or a full rate, really, we weren't always covering our costs of those procedures. So I just think that's really important, to offer options for your patients to make sure that you can collect the patient liability upfront. We do see patients who use our care card across the system. They will come to a clinic appointment later and they'll, swipe their card for a copay. So I think from the patient's perspective, it does provide them with, ease of use and really ease of mind that they have that everything on a payment plan. It's all automatic, it'll update, and they can still afford their monthly payment. So I think that's a really good benefit for our patients.
Excellent. We covered the post-service kind of at the intro, so I'll dive right in. I think, that's how we started at Payzen, and really the thesis was that, there is a patient population out there that wants to do the right thing, or a big patient population out there that wants to do the right thing. They want to pay, and they will come to the table if you make it affordable and easy for them. I think, that's why every hospital out there offers some sort of payment plans, monthly payment arrangements. In the post-care side, I think what we see is, that frequently there's some limit around how far out a hospital will go. That's going to dictate it by balance sheet and other metrics like day and AR. We see that being 12-month, 24-month. And then a lot of times the payments that can be offered in-house are really driven by the amount. So there's kind of more of a simple table in the background, and then some supervisor approval around what payment is offered to what patient. And, many times it's also more reactive. So if a patient calls in, we work with them, but there's a large amount of patients, that won't call in. And if they're not really see a clear path and to paying their bill, they'll ignore it. And so what we've seen with the technology we created, if you pair that, if you go to the next page, if you pair that with what you're doing in-house, you can have better results. You can bring a population that would have ordinarily gone down to the bad debt path. You could bring them to the table. You can convert them to paying patients. And, the way we do that is by being, proactive and targeted in kind of outbound outreach. So, as mentioned before, text message is a very successful channel for us to get a patient's attention and get a right offer in front of them. Obviously, you want to be mindful to not cannibalize the pay in full population, so there's some strategy behind it. And then when you have a patient's attention, really giving them an affordable option that's customized to what they can truly pay. There's a lot of data we can pull on a patient's financial situation in the background, and we can use that to inform what offers are put in front of the patients. And then also making the entire process really easy and integrated with kind of the workflows and the patient financial experience overall. You know, as an example, if someone is on a payment plan, kind of automatically posting back into Epic, so all the other workflows kind of work the right way. So, you know, that's kind of how we've built this, and the benefits we've seen kind of in a nutshell. You know, more patients will come to the table to pay rather than being sent to bad debt. And actually, if someone is on an arrangement that's serviced or funded through Payzen, they're more successful making their monthly payments, and we'll cover that in a little bit. You know, if we talk about just similar to the card, kind of what informed, or what were we looking to do with our plan product? You know, the anchor was bring these additional patients to the table that want to do the right thing, that want to pay, but, you know, can't, and make it easy for them. And kind of the other main thing was it should be kind of an automated process that could be run in addition to kind of manual processes or all the other processes that the hospital system already does. So it's not kind of meant to be kind of a rip and replace. It could be layered on top, and it doesn't rely on hospital health system staff of kind of promoting it, doing phone transfers and so on. And it has the same premise that we had on the card, to say, if someone wants to pay for their balance, we should say yes, and we should figure out the math behind it between the hospital and Payzen. So 100% approval, no interest, no fees, kind of a lot of the same benefits that an in-house plan has for the patient. And then really also the approach we take to servicing that, so collecting the monthly payments, needs to be appropriate for the use case. So this is, you know, non-elective medical bill. Someone didn't go out and buy a flat screen TV. So, you know, how patients are treated when they do fall behind is important. Our philosophy is to offer various ways for them to get back on track, various modifications, as we call them, and never pursue kind of aggressive collection tactics, you know, similar how the hospital would want their patients to be treated. In the back end of it, we offer kind of a host of financing options for the hospital. Our, you know, to free up that balance sheet capital, reduce days in AR, our most popular option is kind of the non-recourse financing option. In that case, you know, Payzen takes on the loss and the default risk. But, you know, we also offer a recourse option or an ability to use our technology only. And you can combine some of this. So we really want it to be kind of pretty modular and the true platform on the financing side as well. You know, Emily, maybe, I mean, you guys are using both card and plans, and you still have in-house plans. Maybe you can talk a bit about your experience with the plans and kind of how it all the whole picture fits together at UTMB.
Sure. So we actually went live with our the back end you know, side first, and this actually was, I think, very beneficial for our patients. I think we send text messages to patients with a balance higher than $250. That's a guarantor balance. And we have, you know, close to 10,000 patients, you know, well, between the back end payment plans as well as the care card, but we have over 10,000 patients who have enrolled and are using these services. And, like I said, we've definitely seen our self-pay collections, patient liability collections go up. So this, and again, just you talked about the technology. I think that, it's really easy for the patient, goes right to a link to their phone, that they can just click on, set up their terms. And you haven't talked about this at all, but if they need to skip a payment, they have ability to do that. They can change their monthly amount. They have a lot of flexibility in creating those payment plans that I can't necessarily offer administratively, from an Epic standpoint. So I think that's really, really beneficial for the patient. And again, I'll just mention the customer service. I have not had any complaints regarding, collections or, any complaints from a patient perspective. Now, I will say in the beginning, it's important to get, get the word out in your organization, because as patients were getting texts, they was the first time they had seen it. It was co-branded, UTMB as well as Payzen. But patients got concerned that they were receiving like spam or, some sort of, junk email or text message. And so, a lot of times they'll, be talking to someone in the clinic or, somewhere in the organization. So it's important that everyone, not everyone, but a lot of people in your organization know that this is starting. And so they know what to expect, because we did have some patients who were concerned about that. But once we got, past that, like I said, we've had really positive feedback, from our patient population, regarding their ability to create these payment plans.
Thank you, Emily. I think the other point, and you were alluding to it already, some options that, we bring to the table in a self-serve way that, some in-house plans don't support. It's important when I think there is a place generally to have kind of a mix of the external option and the in-house plan side by side, and where to draw the line and how to optimize that mix. I think a baseline is to have a good understanding of the all-in costs of an in-house plan, right? $1,000 that's enrolled in an in-house plan doesn't mean $1,000 of cash to the health system, especially if you're talking about the more extended terms, 12-month plus. Clearly the biggest part there is, along that journey, patients default. And I know like Epic doesn't have super clean reporting on it, but kind of one way we found to look at it is to look at, patient balances that were enrolled in in-house plans a little back, let's say like 2022, 2021 on 12-month plus plan, and then see how they're faring today. How much was collected, how much is delinquent. It'll take time for these losses to come in. If you just look at the aggregate number, any new payment plan isn't going to have a lot of losses, but within kind of the first 12 to 18 months, that's when things happen to patients and, patients start falling behind. So I think that's one of them, clearly the biggest factor when you think about the all-in costs of an in-house plan. The next factor is capital cost. I think it, a couple of years back didn't really used to be a big factor because interest rates were low. So capital costs, borrowing costs for health systems were pretty low. I think now that they've gone up across the market, I think it's another one to think about. Okay, what the capital that's tied up there, what are the costs of that, and what could it be used for elsewhere? And then finally, administrative costs. I think, starts with payment processing costs. Processing a card, as an example, has costs. Early out compensation, and then less explicit but still meaningful, like all the internal staff that's handling reconciling in-house plans. So really important to get kind of a full picture, end-to-end picture here. And I think if we go to the next page, what we find a lot of times when we do this analysis is that for the 12-month plus plans, about half of the amount that's enrolled is kind of like the bottom line impact. to the health system once you net out kind of all these costs. Let's kind of keep going through relatively quickly. I want to make sure we still have some time for Q&A. I think here is just, okay, how have you thought about an external option? And clearly, I think probably most of you have been pitched by either us or some patient finance player out there in the market. But what's the picture here in terms of, have you chosen a vendor? Have you considered a vendor? I think that makes sense. And I think, maybe turning it over to Emily, kind of what made you look externally for a vendor, back in the day when you started the RFP, rather than kind of tackling it internally?
Well, again, I would say our primary motivation was around pre-service. So I really needed the ability to offer our patients an option, really to solve for those higher out-of-pocket or higher patient liability in our procedural areas. That was really the primary motivation. Certainly we were focused on point of service collections and, a lot of efforts around collecting co-pays. But really, when you're talking about those higher out of pockets, when we talked about this earlier, just, that care avoidance or, that struggle with your, proceduralists on, wanting to proceed to see a patient with really, without collecting the full patient liability. Which in the end, it is not the right thing to do. And, we all live in this, unfortunately, just the healthcare environment where we're providing services and trying to collect later. And we know that just doesn't work. So that was really my biggest motivation, was collecting at the time of service.
That makes sense. And yeah, I think if you kind of see the feedback from the group here, I think it's 20th, the largest group, but not by a lot, is currently using patient finance vendor, and then close to everybody has heard or considered one. Few have decided against it. So clearly it's kind of top of people's mind around what options are out there. I think one of the top questions to ask really will move the needle for the health system. So ability to increase, the amount of paying patients without cannibalizing the pay in full population. Now, the drivers of this are really, the automation, the proactive nature of it, kind of the integration with kind of existing processes and workflows, the ease of use, the affordability. So kind of detailed questions to ask when you are looking at a vendor is, how is this program going to be offered? Is it going to rely on my staff as a hospital to promote it? Or, are there own channels out there that will get the word out to patients? How are the monthly patient payments determined? Is it really tailored to what someone can afford? And then how are the plans being serviced? As an example, like we've just ran across this recently in another competitive situation, a recourse program with a bank, may sound cheap because the capital costs or the initial kind of headline rate that's quoted is cheap, but then there's so much friction in the process, and it really relies on the hospital's staff to promote the program, that in that case, really it didn't add much to the bottom line. There was kind of a few $100,000 enrolled in this program, and compare that to kind of the close to $1 million a month we do with Payzen does with our automated process for like similarly sized systems. So I think that's kind of one big factor. The other one is, similarly, like some non-recourse programs, well, they decline half the percentage of the population or incentivize paying full with a discount. So they're just kind of skimming off the best paying population and kind of leaving the health system with the rest. So really, really important to look at kind of overall how will it move the needle for the health system. And then, impact on the balance sheet. It's important to get an apples to apples comparison. There's so many different models out there. Obviously, in a recourse program, the health system still on the hook for the losses. A lot of times this dynamic that I described, right? The headline recourse number will look pretty good, but because it's a mix of mature vintages and then kind of new vintages, especially if you start a new program initially, will look good, but then over time as things mature, kind of see the true recourse picture emerge. So it's important to understand that. And then, the traditional non-recourse programs input the cost on the patient in terms of interest, late fees, retroactive interest. These are all practices that regulators have started to look at and that we think are not appropriate for this use case and are risky. So, I think those are the two things I think are main questions to ask when you look at the various options. And, since with UTMB, we went through an RFP process. I think maybe Emily, from your words, kind of what are the things that you were evaluating the various vendors at, and kind of what were your decision criteria?
Well, I mean, certainly we wanted to improve our cash flow and improve our performance in patient liability collections. But really, even more important than that, I would say that the number one thing for us, or for me, is customer service. Certainly you would want to partner with a company, because really, at the end of the day, they're going to look at UTMB, right? So if they're getting these hard calls from a vendor, it's a UTMB balance, and so they're going to end up calling us. So customer service, I would say, is really at the top of the list as far as anyone we would want to be partners with. We want to make sure that they're providing the utmost level of customer service to our patients. And then I would say, which I mentioned before, just the flexibility and the automation. That also I think is very important.
Yeah, makes sense. I think, just briefly takeaways, and then we can go into questions. Clearly, given all these pressures, given the changing environment, I think patient rev cycle needs to evolve. Just staying with the status quo is not a good option. Pre-service is clearly an area of opportunity. We see kind of across all the health systems we work with. And then on the post-service side, I think most hospitals can achieve better results when they, complement what they do in-house with an external option. More paying patients, better economics than in-house plans, especially on the longer terms. And then when choosing a partner, it's really important to look at the true value of the partnership. How much is this partner growing the pie, and not just comparing headline prices. And if you do compare headline prices, making sure you kind of have an apples to apples view. I've seen throughout that there have been a good number of questions, so maybe we'll dive into the questions right away.
Perfect, yeah. And Tobias and Emily, first off, just thank you all so much for all the good information here and taking the time to do this presentation with us, and we'll hop straight into the questions. So one of the big questions I've seen here is, you mentioned Epic several times. Does PayZen integrate with Epic exclusively, or do you integrate and work with other systems as well?
No, we work with all EMR, EHR systems. I mentioned Epic a lot. Obviously, it's the UTMBs using Epic, and it's increasingly is the most common system we integrate with. But yeah, we certainly have kind of Cerner, Meditech, IDX, Paragon, Athena. We have pretty much all scripts. We have pretty much all integrations with all systems at this point.
Perfect. And Emily, a couple questions for you. I got two in one. How do you encourage payments upfront before services are rendered? This is different for patients who are typically used for paying for services after they've been rendered. And the second part would be, what do orgs find motivates a patient to leave a deposit pre-service?
Well, I really think that you have to change your policy, right? It's really more, we're not, asking the patient, it's really more of a requirement in order to proceed with services. Certainly there's going to be exceptions, but really to capture, I would say that 80–85%. But certainly you want to get buy-in from your organization, like in my example, we talked about, we have 100 clinics across, the region. And so, really working with my partners over in ambulatory as far as, collecting from a copay perspective, and sometimes deductible and co-insurance if they're having a procedure in the clinic, that type of thing. Also, working with your marketing team, for any documentation that can be handed to the patient. You can also put information in my chart, just regarding what that policy is. And really approaching it more as a requirement, that's in setting the expectation with your patients that in order to proceed, they do have to fulfill their patient liability. And again, I go back to, you want to be able to, you don't want to, really draw that hard line without the ability to offer them options, right? And so it was really important to us to get PAYSN in place so that we can offer that option. So really the patient doesn't, have the ability to just say, I can't pay that, because they can create their payment plan. They can, select, their terms and their payment amounts monthly, those types of things. And so, it's important to have an option for them.
Perfect. And Emily, one more question in regards to that. What were some of the business points that helped you persuade other UT leadership to help you initially proceed with this methodology? And could you share any counter agreements that were relayed as concerns when you were initially having these conversations?
So really, I would say what helped me just really sell it across the organization was our bad debt numbers, right? So we were writing off, and again, we separated out our unfunded population and our self-pay after insurance. And I actually also look at it, we have our inpatient population, we have our ambulatory population, and we have our ER population. So really I'm looking at that segment of outpatient, which is scheduled elective services, to where patients, should be required to pay their patient liability. The ER is a different animal, inpatient is a different animal, but when you're really looking at scheduled elective services, there's not any reason why you wouldn't collect that patient liability upfront. So I think that really, helped me sell it across the organizations, having your data, in that way.
It's a great answer. And Tobias, if you don't mind, how is PAYSN able to offer this service interest-free to patients? Is there a one-time fee for them to join, or can you tell us more about that?
Yeah, and I'll say, you kind of seen throughout the presentation, I think we've really leaned heavily into our technology and our automation, because I think that's ultimately what drives the value. And on the back end, our most common financing solution is the non-recourse solution. And in that case, the way we do it is basically, when a patient enrolls, let's say for $1,000 balance, we run our model and think like, okay, how much of that $1,000 balance is likely to get collected? What are our costs associated with it? So basically the hospital gets paid less than the $1,000, but the comparison to do is really, okay, what is a hospital getting paid by us versus what would they do on their own, on their in-house plans? And a lot of times, because we do a better job at underwriting the patients and getting those patient payments, we pay a hospital more upfront than they would collect over time on those longer range plans. But essentially, that's how the economics work.
Perfect. And at the very beginning, we had a couple of people ask, would the PowerPoint be available after this webinar or the slide deck?
Yes, I mean, yes, from our perspective, I don't know if the HFMA has different rules around it, but we're certainly happy to share it and kind of tell you more about Payson and our offering.
Perfect. We'll get together with that then after this. And two more questions and we'll wrap this up. The first question is going to be, what is the decision criteria to move an account to pays in versus early out? If the account stays with pays in, what decision criteria is used to send it on to the early out or the bad debt?
Yeah, I think don't think of this as kind of a placement with another early out, right? I think what Payson does is going in parallel to your early out efforts. I mean, in most hospital systems, there is an early out involved, and I think really it comes down to two things. One is, making sure the experience to the patient's coordinated. So there's like some timing when the early out places calls, and then some timing when Payson sends engagement. In the end, it's all kind of branded and white labeled to the health system, so it doesn't feel like, okay, what's going on here. And then the other part is the financial picture on the back end. When we post into the host system, we post with a specific payment code. So, you can exclude it from your early out compensation. So really, Payson goes on in parallel to your early out process. It doesn't replace it. And then kind of at the back end of the bad debt, accounts that don't enroll in a Payson plan, they would still go to bad debt at day 120 or whenever your policy sends them to bad debt. So that process wouldn't be touched either. The good news is a bunch of patients now opt in rather than being sent to bad debt. So you should see your bad debt numbers come down.
Perfect. And one final question. With the usage of the care card, where are these funds coming from?
The funds initially are coming from Payson, so similar to kind of a non-recourse product on the back end. We're pre-funding the hospital system. We're taking an allowance for, okay, how much are we truly going to collect? What is our cost going to be? And we're going to invoice that to the hospital system. But, the upfront balance is getting paid by Payson, and then the patient pays back Payson over time for the outstanding balance.
Perfect. Well, we appreciate it. And to all the attendees, please remember to keep an eye out for the event feedback survey. It'll be sent within 2 business days. We will need that to be answered in order to receive your CPE credit. Other than that, Tobias and Emily, thank you all so much for your presentation and your time today. Thank you to everyone who's attended this Region 9 webinar hosted by the Texas Gulf Coast chapter. And we look forward to seeing you all on the next one.
Yeah. Thank you all. Thank you for having us.
Thank you very much.
Thanks, everybody.